First of all, good afternoon to everybody. As you know, the patient who has at the same time an atrial fibrillation and an acute coronary syndrome, and for this reason undergoes, for example, to a PCI, it's a real conundrum for our therapeutic decisions. And unfortunately, this kind of patients are not so infrequent. It has been calculated that about 1 out of 5 patients with atrial fibrillation undergoes to a percutaneous coronary intervention during his lifetime. On the other side, we know that about 1 out of 10 patients which undergo to PCI, they also have an atrial fibrillation, a pre-existing atrial fibrillation or a de novo atrial fibrillation, a periprocedural atrial fibrillation. Well, in this patient, the therapeutic decision is very difficult because we have to use at the same time an oral anticoagulant drug and one or two antiplatelet therapy. So we have to do a dual or triple antithrombotic therapy given by the association of an anticoagulant and an antiplatelet therapy. In this patient, so we have to manage a three-dimensional risk, a cardioembolic risk, a coronary risk, and of course, a bleeding risk. More unfortunately, antiplatelets, they interact strictly with anticoagulants. This is an example. As you can see, the inhibition of thrombin generation induced by edoxaban is highly increased by the use of ticagrelor, but the same would be for other antiplatelet therapies such like clopidogrel or prasugrel. So very difficult situation. This field of medicine is one field in which cardiologists, they changed their mind very quickly in the last years. As you remember, probably the American guidelines in 2011 suggested the use of triple therapy for 6 to 12 months after PCI in atrial fibrillation patients. So the triple therapy was a kind of must for these patients. In the last years, anyway, we changed progressively our mind, mainly because of 3 reasons, let's say. The first reason is that now we are using stents which are much more safe. They induce much less stent thrombosis. The second reason is that we learned to give the right importance to the bleedings. Bleedings are not soft adverse events, they are hard adverse events. And there is a tight relationship between bleedings and mortality, as we have seen in several trials. This is just the case of OASIS trials, but in many trials have been demonstrated that an increase in bleedings leads to an increase in mortality. But the most important reason why we changed our mind from triple to dual therapy is that recently have been published the results of 5 randomized trials comparing dual versus triple therapy. The results, in extreme summary, the results of these 5 trials is that dual therapy, which means oral anticoagulant plus only one antiplatelet drug, which is usually clopidogrel, induce much less major bleedings than triple therapy, which is mainly constituted by oral anticoagulant plus 2 antiplatelet therapy drugs. So the recent guidelines, here are the American guidelines, they suggest to use triple therapy, this one only peri-PCI, means before discharge. After discharge, they suggest to interrupt aspirin and give only oral anticoagulant plus clopidogrel, let's say, without aspirin. Only in patients at high ischemic risk but at low bleeding risk, they suggest 1 month of triple therapy. But now 6 or 12 months of triple therapy are not suggested anymore by any guidelines. More recently, we have also European guidelines on this kind of patients, which say exactly the same things that the North American consensus guidelines. So triple therapy only during hospital stay, after discharge only dual therapy, triple therapy only for patients at high ischemic risk. But of course, not all that glitters is gold, unfortunately. And also dual therapy has some problems. The most important problem is this one, in my opinion. As we said, less bleedings means less cardiovascular events. But in this case, it's not true, because we don't have a translation of the reduction in the bleedings into an improved outcome in adverse coronary events. Actually, all-cause death is slightly increased by dual therapy instead of versus triple therapy. And even more evident is the increase of stent thrombosis with dual therapy. So we have with dual therapy less bleedings, but we also have more stent thrombosis, especially in the first weeks after PCI. Let's try to understand why it happens. Let's go to see, for example, the ENTRUST trial, which is the one which gave the less advantage, the less evident advantage in terms of bleedings with dual therapy compared to triple therapy. This trial compared the dual therapy with the edoxaban plus clopidogrel, let's say, against the triple therapy with the warfarin plus 2 antiplatelet therapy drugs. If we see the triple therapy arm, the one with warfarin plus double antiplatelet drugs, we see that actually warfarin didn't induce a therapeutic anticoagulation for at least 2 weeks, because the INR was less than 2 in the majority of patients for the first 2 weeks, let's say. So in this short time window, 2 weeks, we can say, actually the comparison was between dual therapy, edoxaban plus clopidogrel, against a dual antiplatelet therapy, because warfarin is not effective in the majority of patients in this time window. And we know that dual therapy with edoxaban plus clopidogrel, if we do a network meta-analysis like in this study, induces more bleedings than the DAPT with aspirin plus clopidogrel. And that's what we see. If you see the left diagram, you can see that the dual arm with anticoagulant, with edoxaban, induced more bleedings than aspirin plus clopidogrel, because warfarin, we said, was not effective yet in this period. But what is surprising, in my opinion, is the right-sided graphic, because we had not only an increase in bleedings with dual therapy, but also an increase in this stroke, myocardial infarction, stent thrombosis. So we had also more coronary events with anticoagulation with respect to patients treated only with antiplatelet therapy. So this data, I think, suggests that the omittance of oral anticoagulation in the first month after acute coronary syndrome results in less bleedings and also in less overall ischemic events. But also the other trials say almost the same things. For example, the Augustus trial, which also compared dual versus therapy showed that in the first month after randomization, the omission of aspirin, the green line, induced an increase in coronary events. This effect was not any more evident after 30 days from randomization, but we can say from this study that aspirin is necessary at least in the first days after PCI. Same things in the other trial, the Pioneer, which used the rivaroxaban instead of apixaban. If we consider only patients undergoing complex PCI, for example, PCIs on bifurcations, we see that the triple therapy prevented very effectively stent thrombosis in these patients. Only 1.3% of stent thrombosis in patients submitted to bifurcation treatment. But in the dual therapy arm, which omitted aspirin, this incidence was 10 times higher. So we know now that dual therapy has its limitations, especially in patients at high risk for stent thrombosis. But the choice between hemorrhages and ischemic events is very difficult. So several authors tried to suggest algorithms to choose between triple and dual therapy. For example, this is the algorithm proposed by Gargiulo and colleagues, which proposed to calculate the bleeding risk and ischemic risk of patients with atrial fibrillation and acute coronary syndrome, and to choose dual or triple according to this graphic. Unfortunately, we don't have patients usually with high ischemic risk but low bleeding risk and vice versa, because the two types of risk are strictly linked between them, because several risk factors for ischemia are also risk factors for bleedings. So the majority of patients actually is in the purple area of this graphic, and it's difficult to choose between dual and triple. So we think that it's necessary to take into consideration also the third dimension of the risk of this patient, which is the cardioembolic risk, the CHA2DS2-VASc score. Why we start oral anticoagulation according to guidelines in low atrial fibrillation at CHA2DS2-VASc score number 2. This because we have a lot of evidence that for CHA2DS2-VASc score 2, the benefit of oral anticoagulation in terms of stroke prevention is larger than the risk of bleedings in these patients. So this is the threshold for initiation of oral anticoagulation according to guidelines. But when we have also acute coronary syndrome associated to atrial fibrillation, and we have to associate oral anticoagulation to antiplatelet therapy, of course, the benefit of oral anticoagulation remains the same in terms of prevention of cardioembolism, but the bleeding risk increases strongly. So we think that in this situation, the threshold to initiate oral anticoagulation should be at higher values of CHA2DS2-VASc score. How can we calculate this higher value of CHA2DS2-VASc score in this specific situation? First of all, we have to take into consideration that, of course, oral anticoagulation is the preferred and best therapy to prevent embolism. But also dual antiplatelet therapy may reduce cardioembolism. It's less effective, but is also effective. So if we try to calculate what is the advantage to initiate an oral anticoagulation, then to do a dual therapy versus a dual antiplatelet therapy without anticoagulation, and we calculate the number needed to be treated with oral anticoagulation to prevent a stroke in the first month after acute coronary syndrome, we see that the NNT, the number needed to be treated, to prevent a stroke is very high for low CHA2DS2-VASc score, which means if I have a CHA2DS2-VASc score 2 or 3, we have to treat at least 200 or 300 patients to prevent only one stroke, using oral anticoagulation instead of dual antiplatelet therapy. But we can also calculate what advantage we have in using, for example, new antiplatelet therapy like clopidogrel or prasugrel instead of clopidogrel, I mean ticagrelor or prasugrel instead of clopidogrel, to prevent coronary events. Of course, also coronary events depend on CHA2DS2-VASc score, and most importantly, after acute coronary syndrome, most of events are in the first 30 days. So we know that using, for example, prasugrel instead of clopidogrel in the first 30 days, we have to treat only 60 patients to prevent a major adverse cardiac event, which is a much lower number than the one we have seen before. So if we plot the two risks, the cardioembolic risk of stroke and the coronary risk of myocardial infarction or death, we can extrapolate that using a new antiplatelet therapy associated with aspirin without anticoagulant, with respect of dual antithrombotic therapy with oral anticoagulant plus clopidogrel, which is the old antiplatelet therapy, we see that the advantage to initiate oral anticoagulation starts only for CHA2DS2-VASc score larger than 4, bigger than 4. But if you use prasugrel instead of ticagrelor, even the advantage is rightward shifted to 5 to 6, let's say, of CHA2DS2-VASc score. But this plot depicts the situation in which we have a simple PCI with low risk of stent thrombosis. But what happens if we perform a PCI at high risk of stent thrombosis, like in case of bifurcations, tortuous vessels, calcified vessels, left main, etc. In this case, the risk of coronary events is much higher, so the plot transforms like this. We don't have anymore any equipoise, and we have an advantage using dual antiplatelet therapy instead of oral anticoagulation at any CHA2DS2-VASc score. The same algorithm can be represented in this other graphic, which shows that if we use ticagrelor and aspirin instead of dual antithrombotic therapy with oral anticoagulation, we have a more favorable situation for DAPT at high complexity PCI for any CHA2DS2-VASc score. Whereas when the PCI is very simple and the risk of ischemic events is low, the equipoise is between 4 and 5. So we think that there is a third situation which has not been considered in the American guidelines and also European guidelines. And this situation is the patient which has at the same time high ischemic risk and high bleeding risk, because the two risks, as we said before, are very often linked one to each other. So in these patients, especially if the CHA2DS2-VASc is moderate, which means below 5, in these patients probably is more useful in the first days, in the first 30 days after PCI, to use aspirin with new inhibitor of P2Y12 inhibitor without oral anticoagulation for 1 month. Then after 1 month, the aspirin can be switched to oral anticoagulation to usual dual antithrombotic therapy. I go to conclude like this. We know that if we compare dual to triple therapy, the bleed to coronary events trade-off is really unclear, especially in patients with both high coronary and high bleeding risk. In these patients, both dual and triple therapy have very strong limitations. If we compare actually dual to DAPT therapy, we should calculate each time the early stroke to coronary events trade-off, because in this patient it could be more useful to use a short course of DAPT instead of dual. Quindi, concluding, an accurate three-dimensional evaluation of the ischemic, hemorrhagic, and embolic risk should guide antithrombotic strategy early after PCI in atrial fibrillation patients. Thank you.